after we complete the bone bioprinting, we started the skin bioprinting. Of course, before we translate anything into a surgical setting, we need to show that we can do the work in vitro, right? We can print cells in vitro. So we use microvalve-based bioprinting technique. Again, shooting droplets. They're about like a few hundred microns in size. So we first optimize the bioprinting parameters that enables us to precisely deposit these droplets on top of each other. So we use the collagen and fibrinogen, and we mix them, and then we crossing them with the thrombin. So here the ST ink, which is the composite of collagen and fibrinogen, is crossing with thrombin in a layer-by-layer fashion. So then we printed the red dermal fibroblast. So the cells, they grow over time, they spread, they like the metrics. So we did not really experience any problems in getting cells growing in these. But of course, the microvalve-based bioprinting, you have a limitation in the cell concentration, the cell density. So you cannot really easily print cell densities over 1 million cells per ml with the droplet, but with the extrusion, you can do much higher cell densities. So then we move to intraoperative setting on the reds. So we have 2 defects. So each time we had the 6 millimeter skin defects created. This is a full thickness skin created. And then the reason why we had 6 is because we actually use the scanner, the 3D scanner. And when we have the composite defect, so we want to differentiate this, the bone and skin defect. So then we waited 4 weeks. So we had 5 groups, like negative control, empty defect, native skin. We also have the ST ink, just the material filling the defect, and the red dermal fibroblast with this material filling the defect. And then this group is the two compartment group. Like we have the red dermal fibroblast in the ST ink, right? It's the dermal layer, and in the epidermal layer we have the KGF loaded. It's the keratinocyte growth factor. So then we examine the wound healing and the reactivation and the printed groups. They expedite the process. So in about 2 weeks we got the wound closure completed. So we look at the mechanical properties of the skin using a skin puncture test experiment. So we basically use a very sharp needle and try to punch the skin and recording the insertion force over time. And as you can see here, the one with the 2 compartments, epidermis and dermis, it reaches a mechanical property that's close to the native skin. And these are some histological images like H&E, Mason trichome. We recognize these blood vessels. Of course, we had some CD31 images not shown in this slide, but we had blood vessels forming, and we have the vimentin showing fibroblasts, and lower green showing the top layer, the epidermal layer, clearly.